I'm going to give you a couple of minutes to look over the goals for this concept. So please look at the 4 goals that we're going to be making sure that we do cover. Now we're going to talk about defining and describing the concept of clinical judgment. Here you're provided with the definition of clinical judgment. And again, as we're practicing, we're expected to respond to a huge host of unexpected events, such as the changes in our patient's schedule, their discharges and admissions. We may have staff situations that arise, or our patient's condition changes, or we may have to reorganize how we do our task and what task we're going to do when. And all of this engages us in a thought process, which is also known as critical thinking. Critical thinking and critical reasoning are used interchangeably. And so please make sure that you do look at the definitions in your textbook on page 387. We also have a process that we use that we call noticing, interpreting, and responding. And we need to have reasons of why we respond the way we do by interpreting the information that we've gathered when we do the noticing portion. So look over this. Also, too, you want to make sure that we understand that how we interpret a situation also may depend on the care setting that our patients are in. And again, making sure that we're able to do effective critical judgment for patients no matter what setting that we're practicing in. When we're looking at the scope of clinical judgment, we look at certain criteria, and we use different tools. One of those tools is our standard-based approach, and this is actually looking at a standardized tool that helps to support our patient care and make sure that we're providing that safe patient care. We may need to select from an algorithm, patient care guidelines, or we may be using decision trees. And as we go from there, as our patients' conditions change, that's kind of preset for us, so we can choose what is the best path for our patient. Another thing that we do use is clinical judgment, is using research, and that's our evidence-based practice. What does the research say? And then we have to make sure that that research supports our particular patient and what they're going through at that moment. So again, we need to know how to apply what's available through research to make sure we get the best results. We need to make sure that our care is safe and effective, and that we have that knowledge behind it. So again, we're going to be using all 3 of these examples when we're looking at how we apply our clinical judgment. Some of the things that we have to remember when it comes to clinical judgment is many times there are not clear-cut answers about nursing care. When you start practicing, you'll want to think back in your textbook, and everything is not textbook. Everything is not crystal clear and clear-cut. Answers are not available. So many times we have to pull from experiences, emotions, our past encounters, values, and understanding along with that, our patient's knowledge base, what's going on with our patient, how well we know our patient, the clinical environment in which we're practicing, and also being able to interpret information that we've gathered. Please make sure to go over and read the attributes and the criteria using clinical judgment. It's on page 388. You have the 3 bullets, and I think it's pretty self-explanatory. So if you want to go through and read over that in your Giddens book. Also, too, it depends on situations. Sometimes we have to recognize a situation that is not the norm. Something that we really need to think about, and lots of times we will pull from others in the clinical care setting. to help us make a decision. And so each nurse has a different experience and has different reasonings why they've chosen a certain path or made a judgment call about their patient. So it's good to get input, especially when you come across a situation that is not within the norm. One of the models that we use is known as the Tanner model, and it is a very circular model because we go back over this over and over. It's not a linear process where we have a beginning point and an end point. We always go back through and reevaluate, and that's the reflection part at the end. So that's why it's circular. So we start off with our knowledge, our experience, our ethical perspectives, and how well and what we know about our patient. And so when we look at that, we go into noticing. What do we notice? What are we collecting? And then how are we going to interpret it and understand what it is our patient's going through, the information we've gathered, and then we're going to respond, and that's the doing part. And then in the end, we're going to reflect back and look back about what we did. Did we make the right decision? How are they progressing? Are they improving? Are they not improving? And so forth. So that's what this process is all about. Your textbook talks about noticing, and this is box 40-1 on page 389, that factors that influence noticing. When we look at noticing, it's a lot of this includes our own background. It also looks at your relationship with your patient and the type of care that you're giving, and also knowing anything you see that's happening, what we can anticipate about our patients. We're going to collect the pertinent information and collect data about this patient. And we also, when we're doing this, we're also thinking what we call a holistic view. We're looking at the entire patient. So it's not just their illness or their sickness or their symptoms, but everything about this patient. And we're also going to start picking up on patterns or trends that we may see when we're looking at how we're going to provide care and what choices we're going to make. When it comes to interpreting, this is where we start to get all that information and analyze what is it telling us, what information do we have. And you're going to see a difference in your practice from the time you begin as a nurse and you're a novice nurse to the time later on that you're an expert. And you'll have different ways that use this interpretation. And so behind the interpretation, we use what we call the reasoning. And it can vary from your expert nurses who are very intuitive and they have that instinct. They've used narrative to kind of look back and storytell about things that have gone on with their patients, and they can come to a conclusion right then and there. So again, taking this and information and interpreting it. In other words, what is it telling us? Then we have responding, and this is the action part. This is the doing, and it depends on our level of expertise. If we can make a judgment of how well our response or what our actions are going to affect the patient. Is it working? Is it not working? And so this is the doing part. This is where we actually go in and we interpret and we respond to our patient's situation from the data that we collected. One of my favorite parts is the reflecting, and this is going back. Did what I did work? Is it working? And so we have two ways of reflecting. We have reflection in action. This is in real time while the care is occurring. Is this working? Am I seeing a difference already? Or reflection on action happens after the patient care occurs, when we go back and we look and say, is there an improvement? If there is, this is why. If not, why is this not happening? A way we do this also is through storytelling and through journaling. So how do we apply this? How do we apply clinical judgment? We can use it in all care settings, and However, we don't always have to use judgment in all of our patient interactions because some things are already preset for us. A great example of application is the type of setting. So if I'm in a setting of an ER, I know what to expect. I know the equipment I have, how to monitor the medications I have, what to expect. So I have everything there, so I don't have to use as much clinical judgment as if someone had a heart attack out in public, say a public park or at a restaurant. I'm going to have to use much more clinical judgment because I don't have all the equipment. I can't put leads on and monitor a patient's heart. I don't have the medications. I don't have the staff. I don't have the equipment. And it's something I don't expect to happen in that setting. So there's a difference in how we apply it, and a lot of it depends on our environment. And these bullets just reiterate what I just said in your last slide. It's going to be easier for your expertise nurse to use that clinical judgment outside of a clinical setting much more than it's going to be for your novice nurse. Please make sure to go back and look at the paragraphs on page 392, talking about reflective practice, applying concepts to nursing practice, and skillful responding, and learning to recognize patterns. Those are, I think, very important paragraphs for you to go back through and read over before we have class. My other favorite is this one here, is interrelated concepts. So we have the main concept of clinical judgment, but we have other concepts that also relate to the main concept. One of those is safety. And so with safety, we need to make sure that our patients are safe at all times. We need to consider that we provide a setting and making sure that we use clinical judgment to keep our patients safe, such as I'm going to use a clinical judgment if I have an elderly patient who just had surgery and they're getting up for the first time, and I need to make that judgment. Do I need someone else to help me get them up, or do I think I can get them up on my own? Using my expertise background, I know anytime I get a patient up for the first time, it's very risky. You don't know how they're going to react or how they're going to respond. So I'm going to get a second nurse to help me up. The other thing we're going to think about is healthcare quality is another one listed, and this is committing to a high quality of care that we're going to be giving our patient. We're going to be looking for patterns, and we're going to use our knowledge about the culture of that unit to organize and inform the staff and inform ourselves about our patient and our patient care. Another one we're going to look at is leadership, because with leadership, we need to know how to delegate and who we can delegate to, and what tasks can be delegated to which staff members. So that's going to be very important as well. The other one is patient education, knowing when and where and who to educate, how frequently we need to educate them, the process, how we're going to educate, whether it's going to be a pamphlet, video, hands-on. Are they ready for the education at that moment? Another one is going to be evidence, and this is our research. What works with our patient care in a particular unit may not always work with another one in another unit. So we have to know which evidence-based research applies to our patient, and so we need to pick out the correct ones. The other one is professional identity. Sorry about that. And with professional identity, this is the interactions with your patients and their families. This is the part where we start to notice and we interpret information, especially from their stories. The last one is going to be care coordination. And this is where we look at situations and we kind of plan when is the best time for this patient to be discharged. And when they go home, what is their home situation? Is it safe for them to go home yet? Do they have stairs? And maybe they live alone, so maybe I should send them to a rehab until they're more stable and can get around. So these are some things that we need to think about. The last thing I want you to do is to look on page 393 at box 40-2, and then on the page 394, not 294 as I have typed there, but on page 394, look at clinical skills, management of care, urgent and emergent situation, and clinical skills. Look at those paragraphs and also look at the case study, and we'll discuss those in class.